By the third trimester, over 67% of pregnant women experience hand and wrist complaints. The breakdown of these pathologies points to two primary diagnoses: carpal tunnel syndrome, a compression of the median nerve in the wrist, and de Quervain's tenosynovitis, which is a painful inflammation of the tendons on the thumb side of the wrist. Despite this prevalence, elective interventions for these conditions are routinely delayed until after the postpartum period. This delay stems from clinical hesitation. Providers often defer indicated treatments due to generalized fears of fetal distress and teratogenic risk, meaning the potential to cause developmental abnormalities in the fetus. Deferring treatment compromises the mother's quality of life. Unmanaged nerve and tendon pain disrupts sleep, daily function, and workplace productivity during a demanding physiological window. We must abandon assumed generalized risk. The solution requires evaluating the quantitative risk profiles of orthopedic interventions. Today, we will correct the clinical calculus across three specific pillars: pharmacotherapy with steroids, operative anesthesia, and trauma imaging. Withholding definitive orthopedic care based on unfounded teratogenic fears actively harms maternal outcomes while providing no proven protective benefit to the fetus. The initiation of upper extremity symptoms during the third trimester is driven by specific systemic physiological shifts. Rapid interstitial fluid volume expansion occurs as maternal hormonal changes force fluid to efficiently cross semi-permeable cellular membranes. This elevated plasma and interstitial fluid volume increases pressure within tight anatomical spaces, compromising structures like the carpal tunnel. A secondary hormonal driver exacerbates this mechanical stress. Elevated levels of relaxin, a hormone that prepares the body for childbirth by loosening ligaments, induces ligamentous laxity in the hand and wrist. Inside the first dorsal compartment of the wrist, this fluid buildup compounds with the mechanical friction generated during ulnar deviation, leading directly to de Quervain's tenosynovitis. When conservative measures like splinting fail, corticosteroid injections serve as the frontline treatment for both conditions. Clinicians often fear steroid use during pregnancy because multiple systemic courses carry documented risks, including maternal hyperglycemia and chorioamnionitis, a bacterial infection of the fetal membranes. However, these systemic risks do not apply to localized interventions. A single non-systemic dose carries a different risk profile because the drug concentration remains at the injection site rather than circulating through the maternal bloodstream. This chart compares the effects of systemic versus local administration. While the left side shows high placental transfer for systemic drugs, the right side demonstrates negligible fetal gut absorption of localized triamcinolone. Evidence suggests no single-dose local corticosteroid causes fetal compromise or congenital malformations. There is one documented postpartum exception. A local steroid injection in the wrist may temporarily suppress lactation for approximately 36 hours. To manage this, clinicians should implement a simple protocol. Counsel postpartum patients to preemptively store adequate breast milk prior to a first dorsal compartment injection. Firmly, single-dose local corticosteroids are a safe, effective frontline therapy. Denying them based on data from systemic steroids is a categorical pharmacological error. If non-surgical treatments fail to alleviate symptoms within 4 to 6 months, the clinical threshold for surgical release is met. The American College of Obstetrics and Gynecologists maintains a clear guideline. A pregnant woman should never be denied an indicated surgery, regardless of her current trimester. The primary intraoperative risk factor is not the procedure itself, but the physiological swelling of the oropharynx and epiglottis, the flap of cartilage at the root of the tongue, inherent to pregnancy. This pregnancy-induced swelling increases the probability of airway loss during the intubation required for general anesthesia. Because of this risk, the anesthetic hierarchy favors regional and local anesthesia to entirely avoid difficult airway management. Regional techniques offer an additional dual benefit. They minimize fetal anesthetic exposure while providing superior postoperative analgesia for the mother. There is a specific caveat when utilizing local anesthetics. Pregnant women naturally exist at a higher risk for systemic toxicity. This table shows maximum weight-based dosages for common local anesthetics: bupivacaine, lidocaine, ropivacaine, and 2-chloroprocaine. For lidocaine, the maximum dose is 7 mg per kilogram with epinephrine, falling to 5 without it. Bupivacaine maintains a strict 3 mg per kilogram limit, regardless of epinephrine. For surgeries involving a viable fetus, continuous fetal heart rate and contraction monitoring must occur before, during, and after the procedure. Operative upper extremity release is safe and indicated during pregnancy, provided the surgical team utilizes regional techniques and adheres to pregnancy-adjusted local anesthetic limits. Beyond elective procedures, pregnant patients present with emergency injuries. Trauma from motor vehicle accidents and falls remains the leading cause of non-obstetric maternal death in the United States. In peripartum trauma, the foundational rule is absolute. Maternal resuscitation always supersedes fetal evaluation. The physiological reasoning is straightforward. Fetal survival is entirely dependent on securing the mother's airway, breathing, and hemodynamics. Yet in orthopedic trauma, providers frequently hesitate to order radiographs due to fears of exposing the fetus to radiation. This logarithmic chart visualizes radiation exposure. The red danger zone threshold for teratogenic risk begins between 50 and 100 milligrays. A standard CT scan hits 25 milligrays, while a single extremity X-ray registers at 0.001 milligrays, vastly below the danger zone. During evaluation or surgery, an intraoperative positioning mandate applies. The patient must be placed in the left lateral decubitus position. If the patient lies flat, the heavily gravid uterus presses down and occludes the inferior vena cava, the major vein returning blood to the heart. Postoperative pharmacology also requires strict adjustment. Mechanical prophylaxis for deep vein thrombosis and low molecular weight heparin are required. However, NSAIDs, warfarin, and aspirin must be strictly avoided due to fetal risks. Prioritizing the fetus by withholding maternal diagnostic imaging or standard advanced trauma life support protocols deviates from evidence-based care and introduces preventable maternal risk. Consolidating these data points yields a comprehensive blueprint for managing the orthopedic peripartum patient. This flowchart, titled Surgical Management of Orthopedic Trauma Patients, outlines the entire decision tree. The preoperative block mandates the ATLS primary survey and aggressive maternal resuscitation, specifically avoiding vasopressors. The intraoperative block issues directives to limit blood loss and deploy regional anesthesia. Finally, the postoperative block emphasizes the mandate for DVT prophylaxis, countering the compounded hypercoagulable state of pregnancy and surgery. Pregnancy modifies a patient's baseline physiology, inducing systemic fluid volume shifts, difficult airways, and hormonal laxity. While these physiological shifts require precise protocol adjustments and pharmacological dosing, they do not invalidate standard orthopedic interventions. By understanding the quantitative data behind steroids, anesthetics, and radiation thresholds, specialists must abandon protective hesitation and deliver definitive care to the pregnant patient.